Wechsler, right? W-E-X-L-E-R, Wechsler scale. These are what we call deep tendon reflexes, or DTRs. DTRs are deep tendon reflexes. And they're based on a scale of 1 to 5. Or actually 0 to 5. So 0 is down here, 5 is up here. We got 4, 3, 2, 1, and then 0. Okay? If we're normal reflexive, okay, so 2 or 3 is going to be what we consider to be normal. When we did Clarissa, she was about a 3. She had a nice brisk response. Now someone like Zach, when we did you, Zach, and you, Erica, you guys would be on what we call a 1 scale. We don't see any movement against gravity, but we know that the muscles are contracting a little bit, what we call muscle setting, just a little bit of tightening up, okay? So this would be normal, right? And here's the other thing. If we test one side and it's whatever it is, and we check another side and it's very different, we want to know why that is. Could it be that you maybe had a previous lumbar disc injury, maybe a piriformis syndrome, or maybe something happening within the brain? We just don't know. We need to further investigate. So a 1 is what we call hyporeflexive. And then the 0 is simply non-responsive. There's no response to this person, or with this person. And then of course up here we would call this hyperreflexive. Okay? With a hyperreflexive patient, when you hit them like this, you're going to see that leg kick out very briskly. Okay? And I mean, you got to get out of the way. If you're the last thing you want to be as a doctor is have the patient right here, and you're hitting them like this, and they smack you in the thigh or somewhere else, right? You don't want that to happen. So that would be hyperreflexive, a very brisk response. What we don't want to see, we don't want to see zeros, we don't want to see zeros, and we don't want to see 5s. 5 is what we call clonus. Clonus looks like this. The leg kicks out, it kind of stays there and kind of shakes for a little bit before it comes back. Okay? We don't want to see that. That's considered a pathological response. All right? We don't want to see zeros, we don't want to see 5s. We want to see somewhere in between, Kate.
So you were saying with the Babinski test, with it being negative or positive, that's not on the scale?
Not part of this, no.
Okay.
With Babinski's, it's either an all or none. That's why we say positive or negative. There's no scale there. If the toes flare out, and that's a positive response. If the toes, if they curl and the person recoils backwards, but as long as the toes curl, they pull back like that, that's also normal. Okay? So this is what we would see with the Wechsler scale. Now we need to explain why we see what we see with the Wechsler scale. And that is this. Okay? We have the brain, and this is in the notes later on, but in the notes, the class notes, the lecture notes later on, this, by the way, is not going to be on the lab test, it'll be on the lecture test. So, but it's a little bit further along. It's like at almost the end of this section before we have our test. But this is the best time to cover it is now. So, what we're going to talk about now is upper and motor neuron lesions relative to this dude right here, the Wechsler scale. So we're going to talk about why we actually use this thing in the first place. So if we look at the brain's up here, and then we've got the spinal cord down below. Okay? And I talked to you guys about this today. Remember I mentioned the multipolar neuron? I said something like an alpha motor neuron. Do you remember me saying that? There's a nerve that comes off the cord and goes out to the skeletal muscle. Okay? This happens to be what we call a lower motor neuron. Lower motor neuron. Lower motor neuron goes from the cord out to the muscle. It's that multipolar neuron we talked about with all the summations, with all the EPSPs and the IPSPs, right? So if a lower motor neuron, Casey, were to fire, what would happen to that muscle? It would contract. That's exactly right. Would you all agree with her? Andy, would you agree? If the lower motor neuron fired, then that muscle would contract, wouldn't it? Okay? Now, I also mentioned to you all that we have other nerves. Remember I did this? Or I put a little alpha motor neuron like this going out to the skeletal muscle over here. But I said we could have literally hundreds of other nerves firing on this one nerve. Did we say that? EPSP, summative effect, right, Julia? Okay? I'm going to draw, Julia, I'm just going to draw one to represent this. But this nerve is what we call an upper motor neuron. Upper motor. That's a stupid Geico. No, that wasn't Geico. That's Progressive. Progressive has terrible commercials. Geicos are funny. This is called an upper motor neuron. This is called a lower motor neuron. So from the brain down to the cord, upper motor neuron. From the cord out to the muscle, lower motor neuron. So let me ask you this, because I talked about this today, EPSPs and IPSPs. What did I say was the main function of all those nerves firing on this most of the time? What did we say? Was it excitatory or inhibitory? What did I say? I said I watched you guys sitting around in the classroom. Most of the time you're sitting like this, weren't you? If you didn't want the muscle to fire, it shouldn't fire. Would it? Or could it? Should it? No, it shouldn't. Otherwise, we'd be like this all the time, sitting in our chairs doing this. Right? We don't want to do that. So what did I say? The majority of the time, the nerves coming from up above, the nerves coming into this motor neuron, we're going to be what? Inhibitory or excitatory? Inhibitory. Inhibitory, yes.
Is that Parkinson's, not being able to control
No,
that?
don't go there yet.
Okay.
You're going to steal my thunder. So we're going to cover that in just a second.
Okay.
So here's the deal. Here's the deal. Upper motor neuron, lower motor neuron. So now we want to talk about if we damage these dudes. If I were to cut this nerve right here. Great example. I told you about this before. Guy puts his hand through a plate glass window, slices the nerve. Will I be able to contract that muscle? No. So if I have a lower motor neuron effect, we call it a lower motor neuron lesion no matter what cause. It could be a disc injury, it could be a cut nerve, but a lower motor neuron lesion causes a flaccid paralysis. Write that down. A lower motor neuron lesion, LMN lesion, equals flaccid paralysis. Well, what does flaccid mean? Limp. Nothing happening. Flaccid paralysis. So, if, let's say I got a disc injury, I do reflexes on one foot or one knee, works fine. But the patient comes in because they got low back pain, right? Reflexes on one leg, oh, that one's fine. Reflexes on the other side, I'm getting maybe a 1 or a 2. Maybe it's a long-standing one, 1 or 2. Or maybe it's a 4, maybe it's a 5 because it's acute, it's inflamed, right? Massage therapist, you know what I'm talking about here. Acute or inflamed, hyperreflexive, and then after a while, because it's that nerve has been pinched, it's first irritated, now it's pinched long-term, chronic, it ends up becoming a 1, maybe a 0, who knows? You with me? Okay, Melissa, good? So a lower motor neuron lesion causes a flaccid paralysis. An upper motor neuron lesion, okay? Whatever could cause that, an upper motor neuron lesion, a lesion is a pathology, it's a problem. An upper motor neuron lesion leads to a spastic paralysis. All right, so what does a spastic paralysis mean? Well, it means we don't have control over the dampening effect that we would normally get from the upper motor neurons, right? So where would we be on this scale here if we did the reflexes on this patient? Up high or down low? What? High. So lower motor neurons typically, especially after they're not acute anymore, will cause this type of response. Upper motor neurons lesions will cause that type of response. So that's why we do DTRs, deep tendon reflexes, because they're part of the picture of putting the puzzle together to answer the questions that we need to answer about the patient's condition. This is what neurologists do all the time. So now we're going to talk about what your question was in context with the spastic paralysis. So what do we say about lower motor neurons? They basically cause excitation. If we fire this alpha motor neuron, the muscle will contract. Am I right? Yes? So what do we know about the main function of the upper motor neurons? Well, we're just sitting here. Most of the time, their function is what? Inhibitory or excitatory? Inhibitory. So what we say is that the upper motor neurons, most of the time, their job is to inhibit. So we're not wasting or burning energy by having excess motion. Okay? We don't want that. So now let's take it into understanding the pathologic realm. So I have said this before, a classic example of an upper motor neuron lesion, and some of you have seen this, many of you have, that's why I use this one first, is cerebral palsy. Anybody know someone or seen someone with cerebral palsy? They have spastic paralyses that last their entire life. And that it can be from, many times it can be from brain damage during childbirth, okay? Or hypoxia during childbirth. Causes brain damage, upper motor neuron, this patient ends up with a spastic paralysis. They have contracted muscles that they can't relax. That's spasticity, isn't it? Right? So that's one example, that's from childbirth, but we can have much more subtle examples of that as well. So a great example would be Parkinson's. Parkinson's is a decrease, and you don't have to write this down, but just think about it. Parkinson's is a decrease in the production of dopamine due to the destruction of something called the substantia nigra inside the brainstem, the midbrain. That means black substance. And on autopsy, when you look at the substantia nigra, it's much lighter in color on the patients with Parkinson's than it is on patients that don't have Parkinson's. So what does Parkinson's cause? Parkinson's cause, initially, what we start to see initially, now later on there's lots of other things that happen, but initially it caused what we call a non-intention tremor. So these patients will walk around and you'll see that their hand maybe has this what we call pill rolling tremor, right? So have you ever seen someone that does this, or maybe their head kind of moves like this, okay? So those are rolling tremors, usually around 60 cycles, 60 hertz, where we see that. But that's an example of an upper motor neuron lesion because dopamine is an inhibitory neurotransmitter. It helps to smooth out the motion of the skeletal muscles. So there you go, that's an example of one. Does that answer your question?
Yeah.
Another example would be MS. MS causes what we call an intention tremor. So for MS patients, they'll be fine as they're standing there. This is early on again, remember, because later on they could end up in wheelchairs or crutches or whatever else, canes. But when they reach out to grab something, they end up with this type of tremor. This is called an intention tremor, which means it's happening during their time that they're trying to do something intentionally, okay? An intention tremor. But then when they're standing and not doing anything, they don't have the intention tremor. ALS will also cause typically these types of tremors. So that's the Lou Gehrig's disease. Early on in the diagnosis, we use these conditions. So remember, spastic paralysis, upper motor neuron lesion, flaccid paralysis, lower motor neuron lesion. Patty.
So babies that are born with spinal bifida, is that typically lower motor neuron lesion that is?
Yeah, so spina bifida, there are two types. There's spina bifida occulta, which means it's hidden, and there might be people in here that have spina bifida occulta. And what we see in that case is simply just a non-median. If we look at the vertebra, I wish I had more of these. I like drawing these because it's more symmetrical for me. If we look at the vertebra from the back view, it looks like this. So spina bifida occulta might see, if you look at it on X-ray, you might see something that looks like this. There's an opening there where the spinal cord and its meninges can kind of leak out into the space. Spina bifida manifest, and some people, we might have one or two people in this room that has this condition. Folic acid is a big one now. You know that folic acid helps prevent these neural tube defects. But spina bifida manifesta, in that case, they'll end up with what we consider to be, there's two types of that then. There's what we call a meningeocele, which means that the meninge has bulged out into that space and protrudes through the skin. And then there's also one called a myelomeningeocele. This one is the one that usually causes paralysis from that level down on down. And what happens in that case is the cord sticks out into that space. Now, to answer your question, the patients that end up with the myelomeningeocele almost always will have that lower motor neuron lesion associated with it. So no problem above the injury, but they're paralyzed below the injury. Any other questions? Okay, I think that's enough. So know the upper lower motor neuron lesions, flaccid and spastic paralysis. That'll be for the lecture test though, but not for lab test. Alrighty? And if you want to finish up or you feel like you're done, you're welcome.